Healthcare by Heerak Christian Kim, Master of Science, Master of Education, Registered Nurse, Clinical Nurse Leader, Certified Nurse Educator, Aspen University. Since 1970s, healthcare transitioned from volume-based payment system to value-based healthcare system. Volume-based payment is payment for each and every service, whereas value-based payment is based on patient outcomes. Especially with the passage of the Affordable Care Act, known as Obamacare, aggressive push started in federal government-funded programs such as the Centers for Medicaid and Medicare Services to pay based on value-based payment system, which only paid out for positive patient outcomes. Obamacare impacted other insurance companies so that healthcare systems such as hospitals have to adapt to the value-based payment system model. Value-based healthcare system focuses on patient outcomes for payment of services. So even if a hospital and nurses provided services in good faith, if the outcome of the patient is negative, then the hospital may not be paid for the services rendered. Value-based payment penalization is seen in patients developing pressure ulcers in the hospital, which would require hospitals to pay for patient care. But it is not only in the area of pressure ulcers, but also in other areas as well, such as stroke management. There are pressure risks for all patients in hospitals because there is lack of activity due to illness. There can be stasis of blood in certain areas of the patient's body, such as heel areas, that can make the patient vulnerable for pressure ulcers. Bony prominences, such as in the sacral area, can also make patients vulnerable to pressure ulcers. Some patients are confined to patient beds due to their condition, and that can raise their risk of pressure ulcers. It is also important to consider that some patients with conditions such as below-the-knee amputations or diabetes may be more prone to develop pressure ulcers. Some medications make patients more vulnerable as well. There are 4 stages of pressure ulcer. The first stage is redness that does not go away when pressed. The second stage is that there is break in skin and partial thickness, loss of dermis or outer layer of the skin that is visible to the nurse. The third stage is full thickness tissue loss down to subcutaneous fat, which does not expose bone, tendon, or muscle. The fourth stage is full thickness tissue loss that exposes bone, tendon, or muscle. Unfortunately, a patient who develops pressure ulcer in hospitals can experience quickly worsening condition for his or her pressure ulcer. Further disadvantage of pressure ulcer is that they do not heal easily, especially for diabetes patients. It is also important to remember that some patients come to hospitals with pressure ulcers from other facilities such as nursing homes. So that is possible to experience rapid worsening of pressure ulcer in patients who already have them. Pressure ulcers can cause sepsis if not properly managed and cared for. And pressure ulcers can delay healing for other conditions or treatments provided by hospitals, such as surgeries. Hospitals may not be paid for new pressure ulcers or degenerating pressure ulcers that insurance companies identify as being negative patient outcomes. Value-based payments reward positive patient outcomes, but penalize hospitals for negative patient outcomes. Admissions documentation is used to determine whether patient outcomes improved or degenerated, especially as relating to pressure ulcers. Hospitals will have to absorb the cost of non-payment by insurance companies, which claim that negative patient outcomes of new or worsening pressure ulcer is hospital's fault. This means that nurses working for free because services rendered in good faith will not be paid for. Financial loss for hospitals can result in lower profits or decreased revenues for hospital projects such as hospital expansions or developing new programs. Value-based payment system impacting hospitals financially in a major way will all means that hospitals need a value-based healthcare trained experts. Clinical nurse leaders are value-based healthcare systems trained nurse leaders who can meet the challenges of hospitals to avoid non-payment of healthcare services rendered in good faith. Traditional leaders in hospitals such as nurse managers are tasked with efficiency of the unit, and staff nurses, but not necessarily trained in value-based payment systems, since value-based payment systems are based on patient outcomes. Regardless of how efficient the hospital unit is run, value-based healthcare requires the need to create clinical nurse leader positions in hospitals that do not have them. Clinical nurse leaders are trained experts in value-based healthcare. CNLs are trained as horizontal leaders to coordinate interdisciplinary care across many different specialties, such as physical therapy, occupational therapy, speech pathology, surgery, hospitalist, and case management. Because CNLs understand financial implications of patient outcome and are trained to input this awareness in all interventions, CNLs are ideally situated to be effective leaders in value-based healthcare systems. Value-based healthcare delivery to prevent pressure ulcers and manage them effectively requires a checklist. Using SWOT analysis, the threats are patients developing new pressure ulcers, which could mean non-payment for healthcare services. Thus, it is necessary for a complete skin assessment of patients on admission so that if the patient comes in with pressure ulcers, and that is documented accurately. Skin assessment should be conducted at every assessment and documented in order to ensure the patient condition improves and to indicate to insurance companies that patient's skin conditions are monitored and managed actively. Registered nurses who identify new wounds or developing wounds that need to be aggressively managed should request a wound consult. Prevention measures should be put into place right away. There are challenges to preventing pressure ulcers, especially during COVID-19 global pandemic. Nurse shortages exist because of many nurses who left the profession early due to COVID-19 global pandemic. Shortage of nurses means increased nurse to patient ratios. Overburdened nurses could mean worse patient outcomes because nurses are humans and cannot do all that they can do for every patient if nurses are overburdened due to increased nurse to patient ratio. Furthermore, patients may refuse skin assessments and come to reject any interventions related to pressure ulcer management. And they may even refuse physical therapy, occupational therapy, or even ambulation. Nurses have to be respectful of patient autonomy, but must document them so that insurance companies know that worsening patient outcome is due to patient non-compliance. Because hospitals are not reimbursed for every service rendered, but for positive patient outcomes, clinical nurse leaders can help meet the challenges that hospitals face in the value-based healthcare payment system. Thus, hospitals that do not have clinical nurse leader positions should create CNL positions. CNLs can help with completion of skin assessment that requires 2 nurses and ensure that skin assessments are done completely and accurately. CNLs can coordinate care with physical therapy, occupational therapy, and other healthcare services in timely fashion to help patient recovery and patient satisfaction. Given the nurse shortages due to COVID-19 global pandemic, CNLs are necessary to prevent financial loss of hospitals and value-based healthcare payment system. Hospital board of directors can create CNL positions for all the units in the hospital to meet the challenges of value-based payment system. The cost of creating dozens of new CNL positions in hospitals to ensure a maximization of value-based healthcare delivery will offset the cost of that are incurred by hospitals due to negative patient outcomes. CNLs are professionally trained, nationally certified, and considered to be clinical experts by the courts, so that having CNLs in the hospitals will make the hospitals more credible, both within healthcare and outside of the healthcare industry. Also, having healthcare value-added healthcare experts, CNLs will increase patient satisfaction. Clinical nurse leaders are a new kind of leaders for the value-based healthcare of the 21st century. CNLs were created by the American Association of Colleges of Nursing, AACN, specifically to meet value-based healthcare requirements of hospitals to meet positive patient outcomes for reimbursement and payment. In this regard, CNLs are the greatest experts in the nursing profession. Officially qualified as experts for value-based healthcare and nationally certified as such, AACN website clearly states this explicitly, and you can visit the website at www.aaCNnursing.org/CNL. Hospital board of directors need to create a budget for new clinical nurse leader positions at the hospitals to meet the challenges of value-based healthcare. Hospital health financial departments must integrate this budget for new CNLs into the annual budget, hospital human resources need to work to hire nationally certified and professionally trained CNLs into new CNL positions. Creation of clinical nurse leader position in the hospitals also requires professional development programs for executives, such as chief executive officer, chief medical officer, chief nursing officer, chief financial officer, chief operating officer, and managers and educators, because value-based healthcare is new, and CNLs were created by AACN to meet the challenges of value-based healthcare in healthcare systems. Some executives, managers, and educators may not be familiar with CNLs or value-based healthcare, so professional development, training in how CNLs can maximize value-based healthcare in the hospital is needed. CNLs are different from managers in that CNLs create processes, whereas managers execute existing processes. CNLs create interventions and processes that meet the needs of value-based healthcare because they are experts in value-based healthcare, professionally and academically trained to meet the challenges of value-based healthcare. CNLs differ from financial officers in the hospital, and the financial officers may lack the clinical expertise to understand how value-based healthcare can impact financial profits of the hospital, whereas CNLs understand the interrelatedness of patient outcomes, financial reimbursement for patient outcomes, and what is needed to fix the problems along the way from admissions to discharge to ensure that the hospital receives full payment within the value-based healthcare paradigm. Hospital Board of Directors can evaluate the CNL effectiveness in the hospital after 1 year in terms of financial efficiency, employment satisfaction, customer satisfaction that impacts value-based healthcare. In conclusion, creating new CNL positions in hospitals and hiring nationally certified CNLs are necessary for hospitals to be financially viable and profitable in the value-based healthcare payment system that every hospital and healthcare center experience in the 21st century. Patient satisfaction is a part of patient outcome matrix, and CNLs effectively integrating various departments in the hospitals will raise patient outcome, patient satisfaction, as well as satisfaction of different healthcare teams and departments. These are the sources used for this presentation.